Our next presentation is going to be from Dr. Roopa Salwan, and she's going to answer, should all patients be transferred for primary PCI and STEMI? Is it feasible in India?
Thank you. Like all the speakers, I would start by thanking the organizers for giving me this privilege to be here. We have dwelled a lot into the interventional nitty-gritties of our intervention, and now I'd be giving you a broader look of interventions in the country. We've all grown up hearing this frame, time is myocardium, time is outcome, and every hour, every minute that is saved in the propagation of an infarct reduces the mortality, improves the quality of life we give our patients. We've been struggling for many years, and we still have so much to do on this. The goal of treatment, unquestionably, is the achievement of early, complete, and sustained epicardial and myocardial reperfusion. Primary angioplasty is superior to fibrinolytic therapy as a reperfusion strategy when performed expeditiously and expertly in high-volume PCI center. It results in a higher infarct-related artery patency, a lower rate of reinfarction, stroke, and death, and delays associated with transfer in real world reduce the advantage of a primary angioplasty noted in randomized trial. There can be never a single approach that would be beneficial for all patients in all situations. The recommendations given by the ACC-AHA, while the steps related to the procedure and drugs we analyze in detail, I think a lot of us overlook that there are strong recommendations for triage and transfer. There have to be ongoing multidisciplinary team meetings between the emergency, the non-PCI capable hospitals that are the referral center and the STEMI receiving centers, and the evidence is level 1. There have to be a process defining identification of the patient, destination protocols at STEMI centers, and transfer protocols for the referral centers. And high-risk patients after thrombolysis can be referred to a PCI-capable center where the decisions which are best for the patients can be taken, after giving appropriate antithrombotic preparation to make the transfer of the patient to the cath lab as safe as possible. The words like rescue angioplasty, facilitated angioplasty have more or less been removed from the recommendations because they only add to confusion, and systematic randomized trials have shown that very early interventions may harm, but later in the course after fibrinolysis, there is the benefit of doing an intervention. Criteria for transferring patients with a low systolic pressure, high heart rate, high Killip class, or extensive changes are clearly defined. And those with a high risk of bleeding with fibrinolysis or late presenters are the ones where transfer should be done. Now, in perspectives on healthcare, what has been clearly seen that it would simplify healthcare if we could show superiority of a dominant delivery model and roll it out nationwide, developing and proving new approaches to create value only once. However, experience suggests that these models do not live up to the promise, and programs that do well in one region may not do well in another. The gap between the generation of knowledge and the widespread implementation of effective strategies are common in medical practice. If you look at the data that was presented at the NIC this year, the total number of primary interventions is close to 20,000 in our country, which constitute 13.4% of all interventions done. If you look at the slide that shows the indication for angioplasty, while 13.4% are primary angioplasties, a sizable chunk of 30% are patients who've had a myocardial infarction recently. So really, we are doing intervention in close to 45% of patients with acute myocardial infarction, 13% being as primaries, and a sizable number being soon after their event. And the cath labs, there are 50% or more that offer primary round the clock, a significant number that accept and do not offer primary where they cannot ensure services are delivered properly. The mean door-to-balloon time reported is 48 minutes in working hours and 74 minutes in off hours. Radial interventions are also increasing, with 20% of primaries being done by the radial route. There has been a significant growth of cath labs in our country. There were only 100 in 1995, and as we look at statistics today, there are 774 cath labs in the country spread widely over all regions. So we are getting the infrastructure in place, but this is what we have to deal with, and we have to make policies that address and embrace the entire population and what we face. This is where the challenge for the pain to door or pain to needle or door to balloon times arise. Now let's look at the data that's come out from the country. The CREATE trial, which was a large study which had 60% of patients with STEMI, only 40% of patients came within the first 4 hours, 60% of patients were thrombolized, and only 8% underwent an intervention. There was a mortality of 8.6%. Close to 80% of the population is urban and semi-urban, and only 5% come by ambulance. A larger number of patients are coming by taxi, private transport, or by public transport. 70% of patients are paying for their treatment. A smaller percentage are covered by insurance or by government, and a very minuscule are getting free treatment. So it is not a disease of the rich. I mean, this I highlighted especially because even 15 years ago when we were going to policymakers, they were shying away that we can't be seen talking about coronary artery disease, it's a disease of the elite. This data created in CREATE definitely tells us it is a disease of middle class. We need to have policymakers wake up and take decisions that are addressing a majority of our population. In another study that recently appeared in the Indian Heart Journal from Lucknow, which analyzed 609 patients, only 5% come in the golden hour. 40% are coming up to 6 hours, another 40% in the 6 to 12 hours, and 15% are late. The pre-hospital delays are related to rationalization, denial, the need to consult senior family members before making these major decisions. Only 3% of patients come by ambulance. Most of them, ambulance services are only used to transfer patients from secondary centers to tertiary centers. There are delays. Only 2% of patients get primary angioplasty, 50% are thrombolized, and a significant number are left on medical therapy, largely because of late presentation. Another data from India, the Tenecteplase Ilaxim India registry, which was 2,100 patients over a year in 248 centers. That's less than 10 patients per center over a year. It was an observational, uncontrolled, self-reported event. The pain to needle time being 120 minutes, where an overall mortality of 3.48% was reported. And though primary is the gold standard, there is enough scope to use thrombolytic therapy, and early use of thrombolytic can always be followed up by an angiography and angioplasty without adding to the immediate stress of transferring an unstable patient and having to arrange finances. So given the contradictory results of registry and patient data, the key questions remain whether thrombolysis can still compete with angioplasty now that there are many cath labs, and whether angioplasty after thrombolysis is beneficial. I'll just refer fast to the FAST AMI trial, which was a trial done in France over a month with a 1-year follow-up in 223 centers, where 30% underwent primary and 30% underwent a thrombolysis. And what they found was that the patients after thrombolysis, 84% subsequently underwent an intervention, but the outcomes, the 1-year outcomes, were no different in the two groups. And the outcomes of patients who did not get any form of reperfusion were far worse than those who got it. So what it really tells us is that even centers which are doing thrombolysis, it's not that they are at a disadvantage, and they should not always worry about upgrading their things, but get the most out of what is available in their system. Now, angioplasty is the most time-sensitive, complex intervention, and teamwork and smooth transition between various care providers is essential. And we have to move from individual excellence to creating centers of excellence. At my hospital, which was started 7 years ago, we have a network of hospitals. We have a chest pain center, and the unique feature we have is the person first attending to chest pain is actually an interventional cardiologist. So all the details of whether the patient will be compliant, finances, all that, you have an on-ground assessment of your patient before you take the patient to the lab. The lab is available 24/7. And we have done 1,200 procedures in the last 8 years. And I did an analysis of 300 patients to see their profile. A good 25% of our patients are less than 50 years in age. A good 75% of patients actually come in the first 6 hours, 25% within the first 2 hours. And we are serving a community that is within 10-kilometer radius of our hospital. 9 a.m. to 9 p.m. constitutes 76% of the interventions, 23% are at night. We have a 24/7 lab, so it doesn't really change our door-to-balloon times. We've had a 5% patients who needed the balloon pump or who had various manifestations of shock. The average door-to-balloon time is 35 minutes. The average duration of stay of 4 days. We've had good outcomes with low mortality, and if we see the whole year till 2012, we started with a high mortality, got it down, and in between we've rounded off to a 5% mortality rate. Now, what our analysis showed that most patients reach on their own. They do accept the procedure once you talk to them and explain to it. Even the referring physicians are aware of it. Patients are self-paying, and good patient outcomes have reinforced their confidence in the systems. Processes have to be unique. While the ambulance services are important, they are not central to the delivery of care. Between 2005 and 2008, the hospital was new. The team led the hospital. It was small, well-coordinated. We were able to achieve magical results, which gave us all a lot of joy. But beyond that, there has been a lot of attrition of cardiologists, EMOs, nurses, and all this is a reality in a growing healthcare sector. And in a revenue-centric corporate model, what value do you put to quality? We need to develop a directive, as the ACC-AHA has done, that mandates the door-to-balloon, door-to-needle targets, that mandates hospitals to invest on robust process development. It takes real commitment from a multidisciplinary team. You have to adopt a continuous process of improvement with ongoing monitoring, modification. Finally, we all are patient-focused. We have to be forward-thinking, and cultural change is what is necessary. The interventional cardiologist has to accept that given our cultural milieu, we have to move out of our labs into the ERs and take charge of the entire process that ensures patient outcomes. A small learning from the NRMI, which was set up in 1990, they, through their knowledge and through the integration, have been able to reduce the door-to-drug times, to reduce the door-to-balloon times, to reduce the mortality in their patients, whether they got lytic or an angioplasty, and the number of centers who are giving door-to-balloon time of less than 90 minutes has been progressively increasing. So I'd conclude by saying that India is a land of diversity. We must accept it. We must customize protocols to make the best of what we have. We have to look beyond ourselves and create strong teams. While self-discipline is the best, directives from the Quality Council, NABH, CSI will enforce hospitals, private and public, to invest in robust processes. The relative low role of pharmacological reperfusion, mechanical reperfusion is there. There's a significant resource issue that limits our ability to implement primary angioplasty in all centers. Although the development of a 24/7 primary angioplasty is laudable, current evidence does not support its use for every patient, particularly for those patients who present very early after the onset of symptoms. An optimal reperfusion pathway, that's a practical tool that combines the best evidence, the best local resource provision, and a pragmatic approach that facilitates decision-making process to improve performance in the delivery of care to a patient with STEMI. The nirvana for healthcare for STEMI would be where interventions are robustly available for all. I thank you all for your attention.